first edition of the Facebook Live series for this year, and we are very excited to be back. My name is Gershenson. I'm the founder and president of Ovarcome, and today I have the absolute pleasure to be joined by Dr. David Gershenson to discuss rare ovarian cancers and the challenges and treatment advances and clinical trials as it relates to this particular type of ovarian cancer. As it is, we feel that we don't talk much about ovarian cancer. We need to change that. And when it comes to rare ovarian cancers, we discuss this even less. So today, we would like to delve a lot deeper into rare ovarian cancers and hear from the expert here what are some of the things that we should know about rare ovarian cancers. Before we get into that, just a little introduction on Dr. Gershenson. He is a world-renowned expert in this field, as we all know, and he is currently conducting several clinical and translational studies of rare ovarian cancers. He's the principal investigator as well as co-principal investigator of several clinical trials focused on novel therapeutics for patients with low-grade serous ovarian cancer here at MD Anderson Cancer Center. So thank you, Dr. Gershenson, for your time. We'll delve right in because we have so much to discuss. So thank you for being with us.
Thank you, Ransi.
So my first question, how are rare ovarian cancers classified and what are the subtypes and what is unique about these types of ovarian cancers? And what should we know about these types of ovarian cancers?
Thank you. So as you know, there are approximately 22,000 new cases of ovarian cancer in the United States annually. There are three broad categories of ovarian cancer. So the most common type is the epithelial type. And in the epithelial type, the most common of those is the high-grade serous that accounts for the highest proportion of all ovarian cancers. But there are several, and particularly four rare subtypes that include low-grade serous, mucinous, endometrioid, and clear cell. And then there is a category called malignant ovarian germ cell tumors. And the third category is sex cord stromal tumors that can be divided into granulosa thecus cell tumors and Sertoli Leidig cell tumors. And I think these tumors are all rare, so we know a lot less about them in many instances than we do about, for instance, high-grade serous carcinoma.
Mm-hmm. And so, in terms of latest and greatest advances that have been made for rare ovarian cancers, can you tell us a little bit about what has changed in the recent past?
Yes. So, the greatest success story in this area is that of malignant ovarian germ cell tumors. And really, that occurred starting in the late 1970s, 1980s, and 1990s with the introduction of the drug cisplatin. And with that, the treatment of these very rare tumors that affect principally very young women, and we can talk more about that, was really earth-shattering in the sense that the cure rates approach 100% in this very rare tumor with the drugs bleomycin, etoposide, and cisplatin. And so that's really the major success story in this area. In sex cord stromal tumors, they are somewhat enigmatic in that we know a lot less about them and we have fewer treatments. They are moderately sensitive to chemotherapy, although not exquisitely like malignant ovarian germ cell tumors. They are also sensitive sometimes to hormonal therapies, anti-estrogen therapies that may be used for breast cancer. And for the rare epithelial types, mucinous, low-grade serous, clear cell, and endometrioid, the biggest breakthrough, I think, in the last decade has been our understanding of the molecular biology of these tumors and what pathways and genes play a role in the pathogenesis of the tumors.
That all sounds really exciting. And so in terms of the treatment regimen, because these are classified as rare ovarian cancers, is there any difference in how you would treat these types of cancers versus the others?
So yes, there are several differences. If you look at the rare epithelial tumors, at least at the initial diagnosis, for the most part, they're treated just like the common high-grade serous type with a combination of Taxol and carboplatin initially.
Mm-hmm.
However, if they recur, treatments may be very different. So for instance, for low-grade serous, we know that those are also hormonally sensitive and may be treated with breast cancer drugs like aromatase inhibitors or tamoxifen. Also, targeted agents have been used much more for these rare types of epithelial tumors because we understand now a lot more about the mutations. For malignant ovarian germ cell tumors, the standard chemotherapy, again since the 1980s, has been the combination of bleomycin, etoposide, and cisplatin. So very different than the treatment for epithelial cancer. For sex cord stromal tumors, the initial treatment has been either with paclitaxel and carboplatin or the combination of bleomycin, etoposide, and cisplatin. And we really don't yet know if one of those regimens is superior to the other.
Okay.
So the treatments can be different depending on the rare cell type.
Okay. And do these types of ovarian cancers, since we are focusing on the rare types, do they present with unique and different symptoms? So for someone to be, we know the classic 5 symptoms or 6 symptoms that occur for ovarian cancer, right? For
Yes.
the population that eventually get diagnosed with this kind of a rare ovarian cancer, do their symptoms differ any, or is it pretty much the same?
For the most part, no. So for the rare epithelial subtypes and for malignant germ cell tumors, they're really pretty much the same. Abdominal discomfort, bloating, persistent abdominal pain, things like that. The only differences would lie in the category of the sex cord stromal tumors. Not all, but many of them may produce either estrogens or androgens. So for instance, even a very young woman or a girl may present with vaginal bleeding. A young girl could present with precocious puberty if they have excess estrogen production by the tumor. And conversely, if the tumor is producing androgens, that may present with hoarseness, or it may present with hair growth, or what we call hirsutism, so that those may be tip-offs in the diagnosis. But those would be the principal differences than with just the typical epithelial types.
And they are distinct differences too, I mean,
Yes.
compared to the classic symptoms that we all know. So thank you for that. And then one of the things that we are particularly interested in is, how these subtypes of ovarian cancer impact the younger women, because we have been receiving quite a few questions from our audience that, when girls as young as 11, 12 years old are getting diagnosed with ovarian cancer, and
Yes.
of course, when you go to a doctor and present with your symptoms, it's very difficult for a frontline physician to say you have ovarian cancer because of the age and other things going on. So for younger women, what advice would you have? We'll come into the treatment part, but just from the diagnosis standpoint, what advice would you have for them? Should they be experiencing these symptoms? What should they do?
Well, if they are experiencing the symptoms, they certainly should see their doctor. They may undergo imaging, and ultrasound would be the most common imaging that would be used. They might undergo some blood tests to look at tumor markers. I would highlight 3 of the rare types that are, I think, germane in terms of talking about girls or young women. The first of those would be malignant ovarian germ cell tumors. So even though they may occur from birth to the elderly, the average age is really in the teens. And so most of the patients we see with this rare subtype are in their teens or maybe early to mid-20s.
And I'm curious, what is the percentage of patients, like total population, that might be? Is it 3%, 5%?
About 5%.
Okay.
About 5%. Likewise, sex cord stromal tumors, most likely granulosa cell tumors, but also Sertoli Leydig cell tumors, can occur in very, very young patients, girls, or the elderly. But we do see a number of patients who are in their 20s and 30s. The good news about both malignant ovarian germ cell tumors and sex cord stromal tumors is they're not 100%, but they're almost always unilateral, meaning they only involve one ovary. So this is really important when you're talking about fertility-sparing surgery to preserve a normal contralateral ovary as well as the uterus to preserve future fertility. So that's really important when we're dealing with girls or young women who have either of these two subtypes. The third type I would mention would be low-grade serous carcinoma. And the average age for that subtype is about 15 to 20 years younger than the typical ovarian cancer. So the average age is in the early 40s, but we have seen patients in their teens and early 20s, even as young as that. So I think it's important to understand some of the nuances related to girls and young women and the types of ovarian cancer that they could develop.
And so when they come to you for anyone for treatment, their future is always something that it's on their minds, right? I
Yes.
mean, in terms of future family planning and things of that nature. So what advice would you have in terms of that for the younger?
Yeah, I think the first key is that because most of these patients are going to undergo initial surgery, and so I think the surgeon, the gynecologic oncologist, or obstetrician gynecologist needs to be very familiar with the fact of the biology of these tumors and the fact that many of them may only involve one ovary. And so the performance of fertility-sparing surgery and the preservation of at least one ovary in the uterus is really key and is possible in most of these patients. I think then the other issue is, as you say, what is their future in terms of fertility? Because that's a concern. I've just seen a patient today who's 30, and she's very concerned about this. She's just been diagnosed with a rare ovarian cancer subtype. I think it's very important to give them counseling related to fertility preservation and what other options moving forward. I think it's important to consult a reproductive endocrine infertility specialist so that they can know better their options. And the options now are several. You can have in vitro fertilization with embryo cryopreservation, freezing of an embryo, or even freezing of an egg that's been retrieved. Or there can be future options later on after they've completed treatment, if they're able to preserve either an ovary, a uterus, or both, ideally both. So I think this area is much broader than it used to be, and I think the options are really myriad for these young patients. But having said that, there are many patients with these rare ovarian subtypes who do require removal of both ovaries and the uterus because of the extent of the cancer. And for them, they may possibly have other options such as surrogacy or adoption.
Right, okay. We would definitely want to know more about the clinical trials that are currently available for patients based on their subtypes of rare ovarian cancers they have, and what should the survivor community know in terms of signing up for clinical trials, their safety and their efficacy?
So I'll highlight a few examples. So I mentioned malignant ovarian germ cell tumors have been really the example of the success story, because even back as early as the 1980s, we were able to cure most of these girls and young women. But the treatment is, significantly intensive with bleomycin, etoposide, and cisplatin. There are late effects to chemotherapy, including possibly compromise in fertility being one of them, although that's not common. So there are relatively new clinical trials in this area where patients can enroll in a trial if they have very early stage disease. They can have surgery alone and actually be monitored and not undergo chemotherapy at all unless they develop a recurrence. And so what we're trying to do is obviously spare them the acute and the late side effects of chemotherapy. And that trial just started in May of last year and is ongoing. Another component of that trial is actually trying to improve side effects from chemotherapy. And instead of using cisplatin, one of the cohorts is receiving carboplatin along with bleomycin and etoposide, so that will, we think, ameliorate many of the side effects of chemotherapy, both acute and possibly late side effects. So that's an example of a clinical trial that's now ongoing. It's an international trial for girls and young women with ovarian germ cell tumors. In the area of sex-cord stromal tumors, we're still trying to determine if there's a best chemotherapy, and we don't know that. We know platinum-based chemotherapy is still the standard, and there's a randomized phase 2 trial in which we're comparing bleomycin, etoposide, cisplatin to Taxol and carboplatin to see if one regimen is better than the other. And that trial is also ongoing. For the rare epithelial types, and another example would be in low-grade serous ovarian cancer, we have been studying a targeted agent called a MEK inhibitor, MEK, and there are a number of these drugs that have been developed by pharmaceuticals. These are currently in clinical trials, and there's also another large clinical trial that has recently been completed, so that we'll have the results of those trials in another year or two. And targeted agents are also being studied in clear cell carcinoma as well, and there have been a number of phase 2 trials, one with sunitinib, another with a drug called dasatinib, and a third one with a drug that inhibits the MET gene. So I think the focus in the rare epithelial types is really on targeted therapies that target either a gene or a pathway that's involved in the development or the growth of the tumor. So those would be some examples of some of the ongoing clinical trials in this area.
So in terms of, there is always this challenge of signing up patients for clinical trials, as we hear all the time. So for these clinical trials that you just mentioned, what has been the adoption rate, and what advice would you have for people who are still thinking about considering to sign up for a clinical trial?
So my advice would be to any woman who either has a new diagnosis or a diagnosis of recurrence of one of these rare subtypes. Number one, I think it's important to try to see somebody who is an expert in this area, and usually those people practice in large centers. Clinicaltrials.gov is a website that features and lists many of these clinical trials, not all, but it gives important information about eligibility criteria, the drugs that are used, potential side effects, and so that's a really good website. Beyond that, I think if patients are interested in clinical trials, which we hope that they check the websites of large medical centers such as MD Anderson Cancer Center to see what clinical trials are being conducted in the area. So those would be a few of the tips that I would give, or advice that I would give to women who are looking for clinical trials. Clinical trials will vary from time to time. They open, they close, and they are also going to vary tremendously from one center to another. There are some national clinical trials, most of which are sponsored by the National Cancer Institute. Others are sponsored by pharmaceuticals, and these can tend to be large phase 2 or phase 3 trials. And but a lot of those are also featured on clinicaltrials.gov.
Okay, thank you so much. Our final question is about BRCA gene mutation in rare ovarian cancer. So is there a link? And if there is, then what are some of the prevention strategies for patients as well as family members that might have the genetic mutation?
So of course the most important link is with the most common subtype, which is high-grade serous. And about 18 to 20% of women who have a high-grade serous carcinoma of the ovary will have a BRCA1 or 2 mutation.
That's quite high in terms of...
That's quite high, but that's the common type, not the rare type. For malignant germ cell tumors and sex cord stromal tumors, there's essentially no relationship to BRCA mutation. For some of the rare subtypes, so in clear cell, some of those patients, although not 18 to 20%, a much smaller percentage may have a BRCA1 or 2 mutation. In low-grade serous, the best studies to date tell us about 6% of women with low-grade serous carcinoma will have a BRCA1 or mutation, 1 or 2 mutation. So it's a much less common in the rare subtypes. But I think generally for all ovarian cancer types, at least within the epithelial category, we are now recommending genetic counseling and possible genetic testing. Not so for malignant ovarian germ cell tumors, because we don't really know that there's any germline mutational link. For sex cord stromal tumors, it's not BRCA, but there is a gene mutation called DICER1 mutation that can run through families and can be associated with some childhood diseases. And so in that very rare subtype, genetic counseling would also be recommended to look not for BRCA, but for DICER1 mutations. But for the BRCA, it's mainly high-grade serous and lesser so clear cell and low-grade serous. And of course, if they are diagnosed with a mutation, then the options would be either prophylactic oophorectomy or salpingectomy, which is now being studied, or if they have not completed childbearing, then it would be very close monitoring.
And so would family members also require testing?
Yes, if there is a BRCA mutation, a woman has a BRCA mutation, yes. Certainly it would be recommended that family members be counseled and in many instances tested as well.
Okay. This is tremendous information. Thank you so much, Dr. Gershenson. Before we leave, there is one thing that I would like to know from you in terms of your message to our audience when it comes to ovarian cancer awareness, when it comes to survivorship, and just talking more about ovarian cancer and bringing more attention to this disease.
Well, as you know, ovarian cancer, because it is in general, even with the common subtypes, it's a rarer cancer than, for instance, breast cancer or colon cancer or lung cancer. So it has not really received the attention it should. I mean, my advice would be for women to pay very close attention to their bodies and to the symptoms. And so if they do develop a persistent discomfort in the abdomen or pain or bloating, and everybody has bloating, but something that's more persistent, that stays with you, then I certainly would advise them to consult their doctor. And the other piece of advice would be if they do have a family history of breast cancer and or ovarian cancer, that could be a clue that there could be a BRCA mutation in the family. Usually not, but I think that's something they should discuss with their physician as well, because they may benefit from genetic counseling and possible testing.
And on that note, I did do my genetic testing because my mom passed away from ovarian cancer, but I did come out negative, which is probably good news. So
it is good news.
So thank you so very much for your time. And do we have any questions? If we don't have any questions, then we will wrap today, and then we will come back with our next episode next month. Thank you so much.
Thank you.